Hi, this is Brian Kim. I'm going to share with you this case of a patient with high myopia who also wanted a refractive cataract surgery result. She has a soft lens and she also requires a toric IOL. And so you're going to see soft lens disassembly, controlling reverse pupillary block, and then doing a toric IOL positioning in this eye. You're going to see how I'm able to disassemble this lens and manipulate the lens in this very deep chamber. So I'm using a cotton tip to make sure the eye is straight. I'm using a corneal marker to help me center and size my rhexis. In this case, I'm using a metal blade for my paracentesis. I'm using the cotton tip to control the eye. You can see it's no different with a metal blade. You want to make sure you're flat to the iris plane so you can get a nice corneal shelf. I'm turning the eye for the other blade now, so making sure that the blade is parallel to the iris plane, so we get a nice corneal shelf, which will allow me to have a nice self-sealing corneal incision. I'm injecting my intracameral lidocaine, and now I'm injecting my intracameral dispersive viscoelastic to inflate the eye. You can see this is a pretty big eye, deep chamber. I'm going to do my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then dive down. And that's the triplanar corneal incision. Do my puncture style Capsulorhexis. I open up the wound a little bit, and then I'm going to puncture with the forceps in the central part of the capsule, pull it downward towards me. You can see that the capsule's trying not to tear towards me, and so I'm finding a place where the tear is able to go. My corneal mark was pretty faint, and so I decided to bring the corneal marker out to get a good idea, and then I go ahead and start my rhexis. Instead of starting subincisionally, it's starting contra-incisionally. So I'm going around, grabbing and re-grabbing every 1 to 2 clock hours, making sure that the Capsulorhexis is nice and well centered and well controlled. Especially with these big eyes and deep chambers, you want to make sure that the rhexis is the appropriate size. Now I'm going to do my capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator underneath the anterior capsulorhexis edge, pointed down, get a nice fluid wave. I'm trying to decompress on the left side now. Again, this is a soft lens. Again, long eye, high myope eye. I'm getting it to wiggle just a little bit. But again, because it's soft, the material is just cheese wiring. I'm not really able to get the lens to spin, but it is somewhat mobile here. I'm going to irrigate the surface of the cornea, make sure my tip is the appropriate length with the sleeve, lift the incision with a chopper, go in with irrigation off to minimize trauma. I'm going to lift the iris edge in order to mitigate the reverse pupillary block. So that was the first step. When you go in with irrigation, you want to lift the iris, and in this case, I use a chopper before I activate the fluid. Place the chopper out to the equator, rotate the phaco tip vertically, and then crushing the lens completely in half. That's the double chop. I place the chopper out to the contralateral equator, pulling it centrally towards the phaco tip, and I crush the right heminucleus, and that is the cross chop maneuver. The first quadrant was able to be emulsified very easily. I pull the second quadrant up with the chopper, and it came out very easily. I'm trying to use high vacuum with the phaco tip to grasp the second heminucleus. You could see that didn't work very well. Rather than perseverating and potentially causing a problem with the high vacuum, I placed the chopper out to the equator and then crushed the lens piece between the chopper and the phaco tip. And now the second heminucleus was divided, and the third and fourth quadrants were emulsified very easily. Manipulated the epinucleus with a chopper, and I was able to remove the epinucleus very nicely. I take the chopper out, push BSS, take the phaco tip out, and then go in with the INA. But before I activate the fluid with the INA, I lift the iris pupil edge with the cannula. I was able to reduce that reverse pupillary block effect. I begin the INA, removing all the cortical material, sweeping underneath the anterior capsulorhexis edge, and removing on the posterior surface as well. It's important to minimize that reverse pupillary block. It does two things. It helps reduce the lens from pushing back so posteriorly. That's really not a big issue. Really, the biggest issue is some patients can have discomfort when they experience that reverse pupillary block. So I push some BSS with the cannula in the subincisional space, but you can see it's quite clean. Now inject some cohesive viscoelastic to fill the capsular bag and anterior chamber. And I'm sweeping on the left side underneath the anterior capsulorhexis edge. And now on the right side. I'm going to inject the single piece acrylic toric intraocular lens into the capsular bag. And I believe this lens needs to be oriented around 90 degrees. And so I'd like to, in this case, because it's a big eye, just releasing the haptics and making sure both haptics are in the bag with the sweep. And then in order to minimize, again, that reverse pupillary block effect, I go in with both instruments, lift the pupil edge with the capsule sweep, and that minimizes, again, that pressure that's created from the pupil against the capsule. So I go underneath the IOL with the INA handpiece, make sure I remove all the viscoelastic from within the bag. I'm polishing underneath the anterior capsule edge, making sure the bag is nice and clean. You see I placed a tip underneath the pupil edge because there was a little bit of reverse pupillary block effect still. I'm pulsing some BSS into the angle, making sure that the angle is clear of any viscoelastic. Now I'm using the ring to align the lens. So the lens needs to be at around 90 degrees. And I like to do it like this because I don't have to use the marks. The marks can be quite disruptive. You have to mark before, after. If I do it this way, I'm able to align the lens perfectly without using any marks. So once I have the lens oriented correctly, I take the INA handpiece out, push BSS, and then I hydrate my incisions. So again, this is a patient with high myopia. Patient also had a soft lens, needed a toric IOL. I was able to perform double chop, cross chop, mechanical fracturing techniques of this very soft lens. And I showed techniques on lifting the iris edge to minimize reverse pupillary block. At each step, you're going to have high irrigation fluid pressure. You want to lift the iris edge. So with the phaco, I lifted it with a chopper. With the INA, I lifted it with the cannula as well as a sweep. And so these are ways to minimize that reverse pupillary block, to provide more patient comfort. And again, a very easy and systematic way to disassemble the soft lens, and also the easy way to align this toric IOL, which ended up being perfectly positioned with this technique. So I hope this was helpful to you, and I thank you for your attention.